Good afternoon, and thank you for joining the RLS Foundation's webinar titled, I've been diagnosed with RLS, now what? My name is Carla Diezenkowski, and I'm the Executive Director at the RLS Foundation. If you're not a Foundation member, and if you would like to view this and other recorded webinars, we invite you to become a member today by going to rls.org. As always, individuals suspecting that they may have RLS should consult a qualified healthcare provider. Information offered in this webinar is for informational purposes and should not be considered as a substitute for the advice of a healthcare provider. Our speaker today, Dr. Andrew Berkowski, cares for patients addressing a wide range of sleep disorders in adults with subspecialization in restless leg syndromes. Before receiving board certification in sleep medicine and neurology, Dr. Berkowski earned his bachelor's degree in religious studies at Stanford University. He returned to his home state of Michigan, graduating from Wayne State University School of Medicine, completing a transitional year internship at Henry Ford Hospital, and receiving neurology residency training at the Detroit Medical Center, Wayne State University. Dr. Berkowski completed his fellowship training in sleep medicine at Stanford University Medical Center. He currently serves on the Foundation's Brain Bank and Medical Bulletin committees. Dr. Berkowski, we thank you for sharing your time and expertise with us today. I now invite you to begin your presentation.
All right, well, thank you, Carla, for that introduction. Carla mentioned that I was a religious studies major, not a 17th century British theater actor, but I'll give this a try. But this is Sir Thomas Willis in 1672, and he says, "Wherefore to some, when being abed they betake themselves to sleep, presently in the arms and legs, leapings and contractions of the tendons, and so great a restlessness and tossings of the members ensue, that the diseased are no more able to sleep than if they were in a place of greatest torture." So this is Sir Thomas Willis in 1672. He was the one who was thought to have first described restless leg syndrome, and he really captures exactly what many of you who have restless legs are experiencing when you have symptoms. And so I do want to mention I have no disclosures or conflicts of interest with this lecture. And a couple notes about this lecture. The Restless Leg Syndrome Foundation nor its Scientific and Medical Advisory Board have influenced this lecture. So this has not been staged, other than the title was not my idea, but everything else is not biased. And the recommendations and conclusions are mostly based on evidence, and they reflect my opinion based on clinical experience, but it might not be consistent with everything of all of the RLS Foundation and its members. So just be aware of that this is more from my vantage point. And then, as Carla had mentioned here, this is for informational purposes only, even though I'm giving you information. You need to discuss any diagnostic or treatment decisions with your own licensed medical professional. So don't just run out and do whatever is mentioned in this lecture without having medical supervision. So if you want to take home 3 important points regarding this lecture, it's to remember the 3 things is that restless leg syndrome is a brain disease involving iron. So if you remember one thing, remember the word iron when it comes to restless leg syndrome and your diagnosis. Lifestyle improvement like nutrition, sleep should be the most important part of relieving symptoms before you even think about medications. And then remember that dopamine agonists, which are abbreviated DAs sometimes, the DA can stand for dangerous. And we'll talk about why that might be, that a treatment might not be good for the condition. And another way of remembering it is that you don't want to allow augmentation. We'll talk about augmentation a little bit today as well. So the title of this lecture is, this webinar is, I've been diagnosed with restless leg syndrome, now what? So the questions, to answer this question, the first question I'd ask back is, do you actually have restless leg syndrome? Because believe it or not, some people don't have it and are being treated for it. It's important to understand the basics of the condition so that you can navigate the condition, particularly in concert with your primary provider or whichever provider is taking care of the condition with you. And then we're going to discuss lifestyle modifications first. And then when you're diagnosed, you do want to avoid dopamine agonists, many of which are FDA approved for restless legs, but many now are recommending you don't use these medications. And then any treatment option you consider, particularly medication treatment, you want to consider these options cautiously. So let's start with restless leg syndrome. It's also called Willis-Ekman disease. So it's abbreviated RLS or RLS-WED, but restless leg syndrome really captures the nature of the disease. My horrible rendition of Sir Thomas Willis just now, he was the English physician who was thought to first describe restless legs. And then this is a picture of Carl Axel Ekman, who was the Swedish neurologist in the last century who coined the term restless legs. And then we coined the condition after him, after he coined the term. So, but restless legs is more commonly the condition diagnosis because it really captures what the condition is. It's really a feeling of restlessness in the legs. So this is kind of the sobering facts that I wanted to convey to you if you've been recently diagnosed with restless legs. And restless legs has been considered by some doctors, particularly about 20 to 30 years ago, to be a made-up condition because all these drugs came out for it, and then people were questioning whether it existed or whether the drug companies made up the condition. So in addition to that, many providers who see people with restless legs, they downplay the effects of the condition. It's not a life-threatening condition, so maybe we're not going to really learn about it or talk about it, or it's the 8th thing on the list. And then there's also a lack of awareness of recent clinical management changes that have been made in the last 10 years. And some practitioners are still practicing based on knowledge from 20 years ago that they learned in medical school. And so the fact is, you, as the person with restless leg syndrome, may know more than your doctor, which is unfortunate, but that often is the case. And the Restless Leg Syndrome Foundation has resources even for doctors and for patients to help educate and spread the word. And as Carla mentioned, I'm on this panel to revamp the recommendations and the guidelines for providers. So you might be able to print this out and hand it to your doctor when we come up with a revised version of these recommendations later this summer. And then you also have to be an advocate for yourself because, again, it's not thought of as a serious condition. So if you want people to take it seriously, you have to speak up about it when you're seeing your doctor or your provider. So what is restless legs? Well, it's really a disorder of mainly the brain, and it involves unpleasant sensations in the legs. There also must be like a restlessness or a fundamental urge to move the legs as well. So what are some of the effects of restless legs? And some of you may have experienced these, but it could be discomfort while lying down or trying to sleep. It could be intolerance of sedentary activities. Back before COVID, we used to go to movie theaters. We used to fly on planes. We don't do that anymore, but back in those days, that used to be very difficult if you had restless legs. And then it can be a discomfort that causes changes to your mood. It could cause anger, frustration, irritability, anxiousness, and there could be a difficulty of falling asleep or getting back to sleep, and that's how it often falls to some of our sleep providers. And then if you're going and doing something, you may need to be on your feet or move around. So sedentary activities just can become very burdensome if you got to move your legs all the time. So what are some of the facts about restless legs that are important? Well, the world prevalence is somewhere between 5 and 14%, meeting the International Restless Leg Syndrome Study Group criteria, which we'll go over in a few slides. But it's actually a very common condition, and it's thought that about 50% of everyone who has restless legs have what we call significant symptoms, where you may want to address these with a doctor. Some people have very mild symptoms where it's just more of a nuisance at times. And it's a condition that's more common in European and Caucasian North American ancestry, so there's a strong genetic component. And women are twice as likely than men to have restless leg syndrome. And about 20% of women will experience restless leg syndrome during pregnancy. So basically 1 out of every 5 pregnant women will have restless leg syndrome during their pregnancies. And then it increases with age. And we can talk more about that, but it's thought that maybe the restless legs gets worse due to other conditions getting worse, more so than that the disease will necessarily get worse as you get older. It's usually more things affect restless legs as one gets older. So to answer the question, I've been diagnosed with restless legs. Now what? Well, Number one, make sure you have it. So let's look at the International Restless Leg Syndrome Study Group criteria. So number one, as I mentioned, you have to have the urge to move the legs. Sometimes it could be other parts of the body, but generally it's going to be in the legs first. The symptoms must either be exclusive only at night, or they must be worse at night. So there must be what we call a circadian component, or it's affected by the time of day, and nighttime is usually the worst time for restless legs. And then it also should be made worse by rest. So if resting the legs doesn't actually trigger the symptoms to be worse, that might be a symptom that's very important in terms of restless legs. And then moving the legs should relieve some of the symptoms, at least while you're doing the movement, like moving the legs, walking around, stretching the legs, etc. And then it can't be accounted for by another condition. So you can't have another condition that explains all the symptoms. It has to be a completely separate condition, although other conditions may affect restless leg syndrome. So I wanted to point out that it can only be diagnosed by a healthcare provider based on your symptoms. So anytime that somebody says, oh, well, this blood test or this sleep study shows you have restless legs, you should be very skeptical if they say that. The only way you can diagnose restless legs is by talking to you and making sure that you have the symptoms that meet the criteria we just went over. So there are conditions that have similar symptoms. So the common one are leg muscle cramps that can occur at nighttime. Another confusing condition could be just joint position discomfort, like you just from having your legs or body part in one position continuously and having to just move them. It's different than that. It's very different than that. And then neuropathy. A lot of people have neuropathy where they have a numbness and tingling. You could have both restless legs and neuropathy, but neuropathy is a distinct condition. And being restlessness, being fidgety is not restless legs syndrome. That usually is completely separate. And then even in children, some children have attention deficit hyperactivity disorder, and that's the cause of their restlessness. They don't actually have restless legs. So one of the comments that I hear from patients are, well, my doctor told me my sleep study showed I have restless leg syndrome. So I would say this is false. What the sleep study shows are a phenomenon called periodic limb movements in sleep. And this is not restless legs syndrome, but it could overlap as well. So what are periodic limb movements in sleep? So this is important because if any of you will have had a sleep study, you may see these on your sleep study. And so this is just kind of an example of one. And you know, I can't be a sleep doctor without showing you a picture of what we look at on a sleep study. And this is the important thing here is that these two channels where you see these kind of amber bursts of electrical activity that we're looking at, this is over a 5-minute period, every 20 to 40 seconds or so, both the right and left lower leg are firing. We're picking it up on it with an electrode sensor. And that's what we call periodic limb movements in sleep. So this is what somebody might see on a sleep study. But it could be a withdrawal movement in one or both legs, kind of like stepping on hot cement, like your leg kind of pulls back. And bed partners may describe this movement or kind of a jerking or kicking movement. So you will probably not experience periodic limb movements because you're asleep. They can occur as you're falling asleep or while you're awake, but generally they're occurring while you're asleep. So you're not going to notice, but your spouse, husband and wife might notice that. And they occur about every 20 to 40 seconds, and they might not be present all the time. So you could do a study and you might not have periodic limb movements, and then you do a second study and you might have them on the second study. So they're inconsistent as well. But the important points are that most people with restless leg syndrome will have periodic limb movements in sleep. However, most people with periodic limb movements don't have restless legs. And so the statistics show that up to 90% of people, if you do multiple sleep studies, they'll eventually have restless legs. With restless legs, will have periodic limb movements. But even getting older, so people who are over 65, about 45% of everyone who's 65 and older have periodic limb movements. So this is very common. And they're seen in other conditions, heart failure, chronic kidney disease, spinal cord injuries can develop periodic limb movements. And then it's can be supportive of restless legs, but the finding of periodic limb movements are neither necessary nor sufficient for the diagnosis. So I think that's important, particularly those of you who have sleep studies. And some of you, if you were diagnosed based on a sleep study, you have to make sure that you actually have the symptoms of restless legs and not just these leg movements. The other problem is people who are treated for their periodic limb movements often run into side effects and other problems. So treatment of periodic limb movements usually does more harm than good. So it's recommended that the leg movements while you're asleep are not treated. We treat symptoms of restless legs while you're awake. So moving on to the next topic is kind of understanding what causes restless legs. So as I mentioned, there are some genetic factors. You don't need to know this stuff, but people do these genetic tests, these homemade genetic kind of screening tests, and some of these actually show up on there, like the 23andMe. MYZ1 and BT-BD9 are the two most common genetic factors. It doesn't mean that you're going to get restless legs, but it means you're at slightly increased risk of developing restless legs, and these can run in families. So the main cause of restless legs is thought to be low iron or poorly transported iron in certain areas of the brain. And then there are also going to be defects in how the brain cells talk to each other involving sensation. So the sensation of this urge to move is an abnormal sensation, and there's defects in these brain pathways that involve this restlessness. And there is evidence for dysfunctional dopamine connections, and we'll talk more about that, but and we'll talk about that right now. So what is the role of dopamine in restless leg syndrome? So dopamine is a chemical of one brain cell talking to another. It's called a neurotransmitter. So it was discovered actually indirectly because drugs that stimulate dopamine were actually found to improve symptoms of restless legs. And I will say they improve symptoms of restless legs at first, and they could worsen the condition later on. And we'll talk more about that. That's what we call augmentation. But that's how it was discovered as a factor. And iron has a strong relationship to restless legs syndrome and to dopamine. So these three things are linked. So for example, this BT-BD9 gene is involved with both dopamine and iron regulation in the brain. So here's my terrible, I'm not a 17th century theater major, but I also didn't major in graphic design. So here's my horrible rendition of the dopamine shipping ports, as I like to call them. So dopamine are like the packages that get sent from one brain cell to another, and then the other brain cell has a shipping port called the dopamine receptor, and that when it binds to the receptor, the package gets delivered, and that kind of stimulates the brain cell, and that kind of shuts off that restless leg syndrome symptoms. And what happens in individuals with restless leg syndrome is that the shipping ports are defective. So now you've got even more packages, you've got even more dopamine than an average person, but the ports are dysfunctional. So they're like weird shaped, they don't work as well. And then the stimulation that's provided is decreased. So the sensations are higher because your brain cells aren't shutting off the sensations as well. That's probably the best way to explain it. So how is iron affecting restless leg syndrome? Well, we know that people with conditions that have low iron levels are more likely to have restless leg syndrome. So that's been observed throughout many years now. And there have been observations as early as the 1970s where iron levels drop at nighttime. And that likely corresponds with restless leg syndrome occurring more at night because the bone marrow takes up the iron to build blood cells, and maybe it sucks some of the iron out of your brain at night, and now you don't have as much iron as you do during the day, so the symptoms are worse at night. And we know iron assists in transporting dopamine in the brain, and we know the two genes that are the highest risks for restless legs are involved with iron metabolism. And then iron studies have shown that certain areas of the brain on MRI are low in iron in people with restless legs compared to those without restless legs syndrome. And then there are also lower iron levels, or ferritin being the blood test for iron. There are lower levels of ferritin in spinal fluid in people with restless legs compared to people who have the same ferritin level. Their spinal fluid levels are actually lower in restless legs. So this is, I won't show too many diagrams today, but in this diagram it shows that as the blood levels of ferritin increase, the brain levels increase more slowly. And not only that, is that people with restless leg syndrome, all the levels are lower in the brain, even if they have the same amount in their blood. So the blood levels could be the same, but the brain levels are quite low, and they go up more slowly. And this is probably one of the hallmark causes of restless leg syndrome. And we haven't fully understood this at this point, but this helps to explain why iron is so important in restless leg syndrome. So back to our initial question, now what? Well, first thing I would recommend is lifestyle changes. So now that you understand the condition better, what are some of the lifestyle changes? Well, we know that in general, everybody's a little bit different, but in general, sitting around all day, like what I do, sitting in front of a desk all day, or even lying down, being inactive, tends to make restless legs worse. But paradoxically, some people report that when they do vigorous activity, like they go for a 20-mile bike ride or they run a half marathon, their restless legs might actually get worse in the evening. And then all of the vices that everybody takes part in, whether it's alcohol, caffeine, or nicotine, these tend to worsen restless legs as well by their effects on the brain. So some of the things that could improve restless legs: moderate activity, walking, particularly at nighttime, warm baths, leg massages like a foam roller. And even there was a study that came out recently on the benefits of yoga and certain stretching exercises in restless legs syndrome. So how does sleep affect restless legs? So restless legs is often managed by sleep specialists, and it's not just because of these periodic limb movements, but it does affect sleep. So sleep hygiene is really important. And one thing I'll mention is just because statistically, many of you will have obstructive sleep apnea, whether you know it or not. Tens of millions of Americans have obstructive sleep apnea, and it actually worsens restless leg syndrome. And then if you have insomnia, where you have trouble falling asleep and staying asleep, that will make restless legs worse as well, and restless legs could make insomnia worse. So in addressing these issues at a sleep clinic would be very important. So how are sleep and obstructive sleep apnea linked? Well, obstructive sleep apnea is a mechanical problem of the throat where it results in snoring, a collapse of the throat, and the brain actually wakes up from sleep a lot, and it causes and often causes low oxygen levels. So the treatment of obstructive sleep apnea independently improves restless leg syndrome. And we think it's due to improved sleep quality, fewer awakenings, reduced inflammation in the body, and improved oxygen levels. And all that helps with restless leg syndrome. So if you think you may have obstructive sleep apnea, that's the time to have a sleep study done, not to look for periodic limb movements again, but actually to look for sleep apnea so you could treat the sleep apnea. So here are some of the tips for sleep hygiene, which you could look at this slide, but I won't spend too much time on it. But really, some of the important tips are to get enough sleep, but not to go to bed too early. So most people need between 7 and 9 hours of sleep. So don't get into bed, 11 hours before your wake up time. So it's good to have a consistent wake up time and go to bed 7 to 8 hours or so before you are going to wake up that day. Because in restless leg syndrome, you really don't want to go to bed too early because you're going to be lying there, you're not going to fall asleep, and then your legs are going to get restless. So these are some of the kind of the general tips, which most of you know a lot of these things, but these are generally good tips for sleep hygiene. Well, I mentioned inflammation, and inflammation is very important. So some of the things that cause inflammation are things like obesity, which goes hand in hand with high insulin levels, increased levels of blood sugar, so people who have pre-diabetes or diabetes, and then even things like foods that irritate the gut. So if you have an allergy to or an intolerance of things like wheat or gluten or dairy, these can cause inflammation and actually contribute to worsening of restless leg. But really, any condition that causes inflammation can worsen restless leg syndrome. And so inflammation in the gut often will lead to poor iron absorption, and that's why your iron levels may drop because of inflammation in the gastrointestinal system. And inflammation can occur in the brain and throughout the body, and it actually blocks iron's transport into the brain. And that's how we think it's obstructive sleep apnea can worsen restless legs, is in part because it increases inflammation. So iron may not be getting into the brain due to the inflammation throughout the body. So moving on to our next topic, now what? Well, if you've gone beyond the lifestyle modifications, the next step is to get your iron levels checked. So before you even think about any type of treatment, you want to move on to getting your iron levels checked. So the blood test for iron. So this is very important. So your ferritin level, ferritin is a storage form of iron. It's not routinely tested unless you're anemic. So you're going to have to request your primary care doctor or whoever is managing restless legs for you to get an iron level checked. And the level needs to be at least 75 nanograms. So the lab might say, well, 20 is normal. Well, 20 might be normal. You know, it might be for a population that might be the 5th percentile level of normal iron. But for restless legs, we want to see it to be at least 75 nanograms per milliliter. And then the transferrin saturation, it's just the iron level divided by the iron binding capacity. And so if you take the iron, usually they'll give you this number, but if you can calculate it as well, but it should be above 20%. So that's like how much storage space you have for iron and how much iron is filling up the bank. So you've got like 20%, you want your iron deposits to be high. So at least 20% for that one. And you want to check this first thing in the morning while fasting, because again, the time of day matters for checking iron levels. And you don't want to take your iron supplement or eat red meat the night before the study. Potentially, you don't want to take an iron supplement 2 days before the study so you can get a nice clean level. And sometimes an important thing to note is that you may not have a low blood count, but you may still have a low iron level. So if you have restless legs, you should not just rely on your hemoglobin level with your blood count. You might still have low iron levels even if your hemoglobin is normal. So in general, what are good sources of iron? Well, there's two forms of iron in general. There's the heme iron, which is found in animal products, and then there's the non-heme iron. And so these are the good sources of non-heme iron, things like almonds, spinach, tofu, chickpeas. But unfortunately, non-heme iron is not as easily absorbed as heme iron. So Popeye ate a lot of spinach back in the day, and he got these big muscles. But Popeye, he probably would have won like a bodybuilding competition if he had just eaten some chicken liver, because he would have had even more iron and really became strong. But so things like beef, liver, all your dark meats are going to have more iron because the iron actually makes them darker. And if you can combine that with other forms of produce, like your steak and broccoli, for example, the vitamin C actually helps to absorb the iron. So you want to eat a lot of whole foods, and if you don't have any issues eating meat, meat is extremely healthy, low in carbohydrates, and that's going to be your best source of natural iron, even more so than all of these other types of things. But if you don't eat meat for various reasons, you want to concentrate on these types of foods to try to get your iron in naturally. So things to be aware of: many of you may have gastrointestinal conditions that could affect restless legs. One very common one is small intestinal bacterial overgrowth. So we talk a lot about the gut microbiome nowadays, and this condition is highly linked to restless leg syndrome. This we call it SIBO for short. As I mentioned, gluten allergy or gluten intolerance, so celiac disease or non-celiac gluten sensitivity can cause restless legs. Bleeding problems like ulcers, diverticulosis, inflammatory bowel disease, Crohn's disease, things that block iron, things that cause inflammation. Bariatric surgery: if you've had a Roux-en-Y gastric bypass, you're supposed to not absorb things, and one of the things you're not going to absorb is going to be iron. So your iron is always going to be low if you've had bariatric surgery. So other medical conditions to think about, not really a condition, but actually a situation, a good situation: pregnancy can cause iron levels to fluctuate. Chronic kidney disease, or if you're on hemodialysis. If you've had cancer or have cancer and you're under chemotherapy, where you're going to be on these different chemicals that can cause low iron levels or anemia. And then particularly in women who have heavy or irregular menstrual cycles, you'll lose a lot of blood and you may not be able to take in enough iron. So your iron levels might be low because of just bleeding and not making up for the iron loss through that. So moving on to the next thing, I just want to mention, you want to avoid medications that trigger restless leg syndrome. So it's all the anti-drugs, as we call them. So for one, it's anti-nausea medications. So things like metoclopramide. So a lot of the nausea medications can trigger restless legs. So be careful with using those if they're prescribed for you. Antidepressants can trigger restless legs, kind of to a mild degree. There's only one antidepressant that seems to be neutral towards restless legs, and that's bupropion, and the brand name is Wellbutrin. So I'm not telling you to stop your antidepressant, but if you had a choice, bupropion would be a better one to use. Now, most of us can work around these drugs, but just be aware that increasing doses of antidepressants can slightly worsen the restless legs because of their interactions in the brain. And then your antihistamines. So sleep aids, Benadryl, Tylenol PM, NyQuil, doxylamine, diphenhydramine, these older antihistamines where they penetrate the brain and cause drowsiness, they can trigger restless legs. And so can antipsychotics. A lot of these antipsychotics are used as sleeping medications, and they can worsen restless legs as well. So let's move on to thinking twice about starting that dopamine agonist your doctor prescribed. So Dr. Winkelman, one of my colleagues at the Restless Leg Syndrome Foundation, he's done an unpublished study so far that close to 70% of primary care providers are still prescribing dopamine agonists. So if you go to your doctor, they're probably going to prescribe a dopamine agonist. So let's talk about why that might be an issue. So dopamine agonists, they work in the brain by stimulating these dopamine connections that I showed you earlier. And the three main ones that are used are pramipexole, ropinirole, and rotigotine. And there's an older one called levodopa or Sinemet, which is actually a dopamine. It's actually pure dopamine. And this one really is not used in restless legs anymore. It was used in the 1990s. It's still used for Parkinson's disease, though. But sometimes people are still prescribing it for restless legs. And these three drugs are actually three of only 4 FDA-approved drugs. So I'm sort of telling you that 3 of the 4 FDA-approved drugs I wouldn't recommend. But they are FDA approved based on short-term trials mostly, but long-term is really the issue with these drugs. And so just be very careful with them. So how did the dopamine agonists work? Well, dopamine agonists are like an alternative delivery service for your dopamine receptors. So USPS, slow delivery, they're not delivering your dopamine packages on time, getting overwhelmed. So Amazon comes in there, and now Amazon is running their drones, and their drones are like dropping packages down your chimney. And that works great. You're getting these deliveries of dopamine, and it's stimulating your brain, and the restless leg symptoms are getting better. So that's kind of how it works. It bypasses this whole system, and it delivers the dopamine. And so they have a controversial role now, and I'm going to talk about that moving forward. So the clinical consensus now is these drugs should not be first line. Now, many restless leg specialists, including me, believe these should not be used except in rare circumstances. So again, 60 to 70% of all physicians and providers are prescribing them as first line. And I'm telling you, they should not be used at all, except in rare circumstances because of the effects that they will cause. So what are the effects? Well, they can make people very sleepy. They can cause sleep attacks during the day. They can cause nausea, and then they can cause impulse control disorders. So that's a big concern. What are impulse control disorders? Well, it's things like drinking too much alcohol, substance use, gambling, compulsive eating, even repetitive tasks. We call that punding. But basically, you might do the same task over and over again, and it's not really, you're unable to control your regular activities. You start doing things too much, and that's a sign of an impulse control disorder that these drugs could cause. But the worst part of the drugs are that they cause what we call augmentation. So what is augmentation? Augmentation comes from the Latin augere, which means to increase. So it's a state in which the restless legs is increased beyond which it could naturally occur. So basically, the drug makes the condition worse than it was originally if you continue to take the medications long term. So what happens? Well, your symptoms can come on earlier. So maybe they came on at 8 or 9 p.m. and now they're coming on at 4 or 5 p.m. They could spread to other areas of the body. It used to affect you below the knees. Now it's spreading up into your torso, into your arms sometimes. The stronger medication, you need higher and higher doses of medication to get the same effect. We call this tolerance. The symptoms can come on faster while resting. So used to be you could go on a 30-minute ride sitting as a passenger in the car. Now you can't even make it in the car 10 minutes without having to get out of the car and walk around. And then sometimes you can actually take the drug and it will trigger the symptom. We call that a paradoxical response. So you take the drug at 3 p.m. and it triggers the symptoms at 3:15. So we start to see that in augmentation. So these are the things to watch out for if you're on a dopamine medication. And one of the reasons why you want to avoid starting a dopamine medication. So what happens to those shipping ports? Well, Amazon comes in there with their drones and they're dropping packages on your doorstep, and all the other companies start to go out of business. So USPS goes out of business, DHL, they're sort of shutting down, UPS is shutting down, and then things get worse over many years. Your drug levels go up, you take more and more of the drug, and then now FedEx is going out of business. So now you've got no shipping companies left except for Amazon, and you've got very few receptors left. Some of the work by Dr. Clemens, who's also a member of the Restless Legs Foundation advisory board, he's actually shown that some of the wrong dopamine receptors start to become more active. Some of the dopamine receptors that actually stimulate restless legs start to increase in function. So the good receptors decrease and the bad receptors might increase in augmentation. So what to do about augmentation? If you're in the position where you're starting to get worse on the dopamine drug, the good news is much of it can be reversed by going off the drug. The bad news is the brain is actually dependent on the dopamine agonist. So you're going to go through a degree of withdrawal before you get better. But the good news is there are many restless leg specialists, many sleep specialists who are skilled at managing augmentation, and it can be assisted with the help of other treatments. And the Restless Leg Syndrome Foundation has many other webinars, particularly on this topic of augmentation, that I'll refer you to as well, which can get in. There's whole webinars just on the topic of augmentation, but I wanted to introduce that, particularly if you're new to the condition, because a lot of doctors are not aware of this, and it's thought to be inevitable. So depending on how long you're on the drug and how high the dose is, we think everyone will eventually develop augmentation if they're taking dopamine agonists. And that's been my experience as a physician as well, as I've never seen anyone who doesn't inevitably get augmentation. So what are the numbers to back this up? Well, one study checked patients over a course of a 3-year period, and about 50% in just 3 years developed at least mild augmentation. 1/5 of all patients developed severe augmentation. Another study which tested pramipexole, in less than 2 years, about 1/3 of patients developed augmentation. And then rotigotine, which is a 24-hour patch, so it sort of masks some of the symptoms of augmentation. Even 13% of patients on rotigotine, where they're getting the drug 24/7, they developed significant augmentation within a 5-year span in various clinical trials. So the numbers are staggering, particularly if you're talking about a lifelong condition. It's going to make you worse in 2 or 3 years. Is this the best long-term treatment? I would question whether it's a good long-term treatment. So then what do you do if you're not going to use dopamine drugs? Well, I would start with iron. Iron makes the most sense to me. So start with iron supplementation. So some examples include ferrous bisglycinate. Ferrous sulfate is commonly at the pharmacy. And you want to target about 65 milligrams of elemental iron with a little bit of vitamin C and you want to take it at nighttime when your iron levels are low, so your body will absorb the iron. And this is generally for people with a good ferritin level of about 50 or so. Sometimes the ferritin level can be falsely elevated, but if you have a normal ferritin, accurate ferritin level, I say, if you're less than 50, take about 65 milligrams. And if you're higher than 50, you'll want to take less iron. So somewhere between 15 and 25 milligrams of elemental iron. So what are the side effects? Burning, sometimes stomach ache. If you're not absorbing the iron well, it can cause constipation or hard stools. Just think of it, it's metal. It's like throwing a bowling ball down your bowels. So if you don't absorb it, you're going to have a lot of metal. It's not going to be soft. So you might get dark stools or hard stools. And then if constipation occurs, you want to reduce your dose in half or maybe alternate days. So constipation could be a sign of taking too much iron. And then you want to repeat your iron studies 12 weeks after you start supplementation to make sure your iron levels are actually going up with the supplementation. Iron infusion is very important. This is a treatment option nowadays at many centers. Well, this is the only way that sometimes people can get their ferritin levels above 75, because most people stop absorbing iron above 75. So an iron supplement may not work once you hit 75 of ferritin. So the only way to get your iron levels higher is to do an infusion of iron. And it bypasses the GI system, so you don't have to absorb it. It's put right into your bloodstream. And it's an instantaneous increase. So it could take you 6 months or a year to get that much iron into your system. And You could get it in 2 hours, and it has few, if any, side effects. So what are the disadvantages to iron infusion? Well, as you can imagine, insurance companies are, quote unquote, not aware that this is a first-line treatment for restless legs. So if you're not really low in iron, they may not cover the infusion. And then it requires a doctor who can actually access an infusion, a nurse or center. So you need a doctor who can actually order iron. So a lot of even sleep specialists can't order an iron infusion at their sleep center or at their medical center. And then there are a lot of myths and legends about infusion reactions, which scare people off. There really are no serious infusion reactions with almost all forms of IV iron. Most of the reactions are very minor, maybe 3 to 5% of the time. Maybe you get muscle aches or some flushing or maybe a headache, but there really are not serious, objective, serious adverse reactions to iron infusions. But people are always afraid of that, and it keeps people from getting them. And then most doctors are unfamiliar with iron infusions, so they're not even going to think about ordering them for people with restless legs. So if you've gotten past the iron supplementation stage and you want to move to the next step, the second question or the next question is, do you really need a medication? So if you really need a medication, you really have to think about how bad your symptoms are if you want to switch to a medication, because they all have side effects. So the first line drugs are called alpha-2 delta ligands. So what are these drugs? Well, there's 3 drugs. There might be more in Europe, but the 3 common drugs in the US are gabapentin, enacarbil, pregabalin, and gabapentin. And I'm sure you've heard of some of these at this point because they're used for many other conditions as well. Horizon is the FDA approved one for restless legs, but sometimes it's very expensive. So some people have to use regular gabapentin. But most major guidelines now are considering these the first line medication if you're going to use a medication. They should be taken in the evening or at night when you have restless leg symptoms. So people who are taking them in the morning, in the middle of the day, if you don't have restless legs in the morning or during the day, you shouldn't be taking these drugs at that time. You want to take them right before your symptoms come on, usually in the evening or at night, because then the effects will wear off by the morning. The side effects of these can include dizziness, drowsiness. Gabapentin can cause leg swelling, and pregabalin has been linked to like decreased mood or depression, very rarely, but be aware of that. And then some of these drugs in combination with other medications can slow down your breathing. So if you have a breathing problem in your sleep, you have to be careful with taking a lot of these alpha-2 delta ligand medications. So Sir Thomas Willis again in 1683. Sometime since I was advised with for a lady of quality who in the night was hindered from sleep by these spasmodic effects, which came upon her only twice per week. Leaving wholly the opium, was able to sleep indifferently well. So this was Sir Thomas Willis, again in the 17th century. So opiate medications, narcotics, have been used for centuries in restless leg syndrome. So the war on opiates aside, you have to be aware that opiates are a treatment for restless legs, and they're a very good treatment. So we are a war on opiates, but this is a potential treatment option for people with severe restless legs. And nowadays, there's more use of, methadone has been the classic drug, but we're using buprenorphine more and more because it has the fewest number of side effects. It's also called Suboxone. Belbuca is a form. And then other drugs have been well studied like oxycodone and hydrocodone. But you may see this, you may know of people who are getting treated for restless legs with opiates, and sometimes they're needed to get people off of the dopamine drugs. Many consider this a second-line treatment even before using a dopamine agonist. And I will say, though, they're rarely needed or used outside of augmentation. So if people get their iron levels, get iron infusions, get their iron levels supplemented, it's pretty rare that people would need opiates unless they actually have augmentation. So, but it's something to be aware of as a potential treatment. So again, do you really need a medication is a question you should ask. Benzodiazepines have been used for restless legs. I do not recommend them personally, but they're called sedative hypnotics. These are some of the drugs names that have been used. They were used more in the 1990s and maybe early 2000s. They really are thought to just put you to sleep rather than improve your symptoms. And again, they can lead to drowsiness, fatigue, impaired memory, and thinking there's sometimes long-term use is associated with dementia. So we're really wanting to avoid these drugs, but they are, there are doctors still prescribing these for restless legs. So just be aware of them. I'm not recommending them though. And then the brain can cause drug dependence. So a lot of these drugs can cause a drug dependence, but benzodiazepines in particular can cause your brain to become dependent on them. So it might be hard to get off of the drug later on. So in terms of future treatments, these are some of the things being looked at right now and in the future. So stimulation devices, low dose naltrexone. There's a whole webinar on SIBO and low dose naltrexone that was from last year. So if you go back into the archives, you can learn about this. As I mentioned, Dr. Clemens' lab in East Carolina is looking into drugs that reverse augmentation. Dipyridamole, ketamine, there's some theoretical benefit to some certain drugs that affect the central nervous system. And then hopefully there'll be some new drugs coming out. Not that I'm aware of them, but that's sort of the idea, is to fix this brain iron problem as we learn more about it. I'm sure in the future there will be drugs to allow iron to get into the brain to where it needs to go, so that you don't have to get iron infusions, which may not always work, but actually to fix this brain iron problem. So to summarize, the things to remember from this lecture: make sure you actually have restless leg syndrome and not another condition like periodic limb movements without restless leg syndrome. Make lifestyle changes first, particularly making sure you're sleeping well, you're getting the correct nutrition, a low inflammation diet that's high in natural sources of iron is going to be particularly helpful for restless legs. Have your iron levels checked, and then you want to aggressively supplement. So you don't want to just supplement to the low level on the lab test. You want to get to the levels that I had mentioned in this lecture, much higher than what the lab tests say. And just remember, dopamine agonists, you really want to be wary of dopamine agony, because they can cause problems, particularly with long-term use. So just be very careful and monitor for augmentation if your provider is going to start you on a drug and that's your best treatment option. I would argue that there are other better treatment options to start first. And then again, you don't have to be treated, but if you're really so bad that you need a medication, if your symptoms are so severe that you need a medication, start with these alpha-2 delta ligand drugs, the gabapentin, pregabalin, gabapentin, and acarbil. You start with those and then move from there. So I'm going to throw it back to Carla, and thankfully I left at least 10 minutes for questions, I think. So I'm happy to take any of these submitted questions that the audience has submitted.
All right, well, I'll go ahead and get started. How do you manage depression and anxiety with RLS when you can't take antidepressants?
Yeah, so I had mentioned that in one of my slides, that antidepressants have serotonin properties, and they can sometimes trigger restless legs to a milder degree. It depends on how important the antidepressant treatment is. So if you're somebody who was started on an antidepressant 20 years ago and now your depression is great and it's under control, talk to your provider about maybe going off the antidepressant to see how you do without it. Alternative treatments could include things like therapy, like actual talking to a social worker or a psychologist, where it's not a medication. Other times you could try a drug, which I mentioned is bupropion, tends to be neutral toward restless leg syndrome. So you could either switch to that or start with that one first. But the bottom line is some people do need antidepressants and you can't go off the drug. So then you want to work your way around it. So you'll still take your antidepressant, but then you might need a treatment for your restless legs, sort of to counteract that symptoms. But typically antidepressants don't cause severe restless legs. They usually cause, milder or more moderate symptoms of restless legs if they are triggering restless legs. So I wouldn't necessarily avoid the antidepressants if they're needed, because depression and anxiety can make restless legs even worse than the antidepressant can. So it's important to have mental health very stable and to be sleeping well.
Next question. I heard that magnesium helps with RLS. Has this been a helpful natural remedy?
So unfortunately, I'm not aware of any evidence to support that, and other specialists I've talked to are not aware of it. I definitely don't know if there's tiny articles on magnesium, but from what I'm aware of, I have not heard of any evidence for that. So this is sort of, it's potentially not helpful. It is used sometimes for sleep, But really the problem is linked to iron and not so much magnesium. And unfortunately, magnesium competes with iron for absorption into the body. So if you took like an iron supplement with a magnesium supplement, it would block the iron from getting in, because back to your chemistry days, the iron and the magnesium are similar chemicals. And so I just worry that it could be counterproductive. So I wouldn't recommend magnesium unless you need it for another condition.
In mild RLS case, is it true that the patient may be better off living with RLS symptoms rather than medicating for them due to the side effects?
Yes, and I mentioned all the side effects from these 3 or 4 main classes of drugs. So nothing is very benign other than iron. So once you're getting beyond iron supplementation or getting an access to an iron infusion, you have to think about, are the symptoms bad enough to warrant treatment? And a lot of the treatments do work. You just have to balance them with the side effects. But if the RLS is more of a nuisance and you can do things like stretching, warm baths, just compression wraps, things like that, those would be far preferable than taking a drug with potential side effects, because even those alpha-2 delta ligand drugs are considered Schedule 5 controlled substances. So they're even a hassle to even get prescribed in some states. So it's always better not to take medications if you don't need them. There's no evidence that just because you have restless legs, it has to be treated with a drug. It's really based on your symptoms. So if you can handle things without medications, that's still going to be better. But just be aware that some people do need medications because their symptoms are just really bad.
Okay. Next question. Peripheral neuropathy and RLS, what's the difference?
So peripheral neuropathy is more of, as it says, it's a nerve damage, particularly to the longest nerves of the body, which are the ones that go all the way down to the toes. And these can be caused by pre-diabetes or diabetes or other conditions that the primary care doctor or a neurologist would have to figure out what the cause of it is. But they cause typically a tingling, a burning sometimes, but more of a numbness or tingling usually in the feet first. And sometimes that could cause discomfort, but it's different. Most people with both neuropathy and restless legs can distinguish between the two. So the neuropathy may make the restless legs worse, but restless legs is a fundamental urge to move the legs. It's not a numbness and tingling per se, although I think some people can describe it like that. They're really two distinct conditions, and one is more in the nerves and one's more in the brain. Restless legs is mostly in the brain rather than the nerves themselves, but they can definitely overlap because the nerves in the brain, it's all wires communicating back to the brain. So some people with neuropathy, which is damage to the nerves, they do have they could have slightly worse restless legs. And some of the treatments for nerve pain are these medications for restless leg syndrome. So sometimes both conditions can be treated with one drug. So that's a potential opportunity there.
Does slow release iron help to relieve RLS?
So again, iron doesn't necessarily relieve RLS when you take it. So the iron is going to relieve restless legs by increasing iron levels over time. So it's not like you take your iron supplement at 5 p.m. and then it works by 6 o'clock. It's if you take iron for several weeks, gradually restless legs hopefully will improve. Slow release iron I don't recommend because it is released more slowly and it goes down the gastrointestinal system and gets released down in the area of the bowels where it's not going to be absorbed. So slow release iron is more, it feels gentler on the stomach because sometimes the iron irritates the stomach. It doesn't damage the stomach, but it causes some irritation for people. So the slow release gets released later, but unfortunately it's slowly released and then not absorbed at all. So it typically it can be very ineffective. So I would recommend any formulation that's just an immediate release formulation and not a slow release formulation. But nobody should think that iron is going to work right away. It's sort of a long-term treatment, like over several weeks, getting the iron levels up will improve restless legs.
I think I'd like to also have you address why it's important to do this under the care and supervision of a physician that is taking iron.
Right. So part of it is the fact that there could be reasons why your iron levels are low if you have low iron, and those need to be looked into because you could have a bleeding condition or other condition where you're not absorbing iron. So you can't just start taking supplements. You also could be taking too much. You could be taking the wrong kind of iron. You could develop side effects from constipation that could cause problems. So this is it is a supplement, but it should be done under medical supervision so that the doctor or provider can be aware of all of what's affecting your entire body, because it's not just one condition. The other conditions affect restless legs, and taking iron can affect other conditions. Taking magnesium can affect iron. So everything you do, including supplements, should be looked into by a healthcare provider. So I agree with that.
Okay. What are the regulations regarding prescribing opioids for out-of-state patients?
Yeah, so this is a very challenging question now. So right now in the virtual world, like I see a lot of patients, more than 50% of my patients virtually, many out of the state of Ohio, and I'm only medically licensed in a couple of states. So it's unclear what the rules are, because it used to be you would see the doctor in person and you'd get the drug where you see the doctor. And now if you're seeing people or you're getting treated by somebody across the country, they may not have a controlled substance license out of state. So the rules on this new era, post-COVID era of virtual care, are unclear on a state-to-state level. So most providers will not want to prescribe opiate medications out of state because they're highly regulated, and they won't know what the laws are or whether it's even allowed. So I personally can only prescribe opiates to states in which I have my license, and I unfortunately will have to have a home doctor, like in the home state for the patient, prescribe the opiates for restless legs, and that requires a lot of buy-in, because it's not well understood by primary care doctors, the role of opiates in restless legs, and sometimes they're not willing to prescribe them. So that's a big issue, and it's still to be determined. So that's a great question, is what we're going to do across state lines now that we have all this virtual care. What are the laws? And I don't think the DEA knows yet, because they never had this problem. It used to be if you lived in New York, you might have somebody from New Jersey or New York getting the prescription. Now you could be practicing in New York and seeing somebody from Florida, and you could prescribe it to Florida electronically. So these are the problems that I face on a day-to-day basis with these opiates, and it's still to be determined. So you want to talk to your healthcare provider, depending on where they're located, as to whether they have the ability or willingness to prescribe out of state. It's going to be unclear to most people. So that's a big problem, and we're going to have to figure that out moving forward, including the DEA, who doesn't know right now. It's state by state, really, and I don't think the states have tackled this question either.
Right. I think, the whole COVID environment has raised a lot of new questions in healthcare. I'll just finish with one last question. What are your thoughts on the use of opiates, methadone, and kratom for the use of RLS, for managing RLS symptoms?
So if people have really severe restless legs and have failed at least the first line treatment and failed iron, then I would recommend opiates as the next line of medications. Methadone has historically been used as the #1 opiate for the most part, based on 30 years of use at this point in restless legs. I have moved to buprenorphine as my #1 drug because it has even fewer side effects than methadone. The clinical studies are not out there yet, but they will be, hopefully. And it's worked extremely well as methadone. So I slightly favor buprenorphine over methadone. Buprenorphine is also Schedule 3, whereas methadone is Schedule 2. But they're very similar. They're much safer opiates than all the other opiates. So that's why those are the two preferred. They tend to work better for restless legs than the other opiates due to some of their chemical properties. Kratom, it's interesting that somebody asks about kratom.
Yeah.
I literally just saw a patient an hour ago who was using kratom for many months. We don't know much about kratom. It's opiate-like, but he had a horrible time trying to get off the kratom. It's opiate-like. It caused some sort of drug dependence, and he's miserable right now. And now he's going to start on buprenorphine as of today. And I've had a couple patients on kratom. We don't know much about it. I would avoid using that one because it's not like taking melatonin or magnesium. This has chemical effects that are opiate-like. I don't think it's been well studied. So it's a little bit too close to a very strong prescription drug. So I would caution people on the use of kratom at this point. I know it's widely available as an herbal, substance in the US, but it may be a very strong herbal substance, and we don't know the effects yet. So we'll put a to be determined on that one. So I really would not recommend it at this point. I would recommend a traditional, well-studied opiate before I'd recommend kratom, based on my experience so far.
I thank you for addressing that too. And we also have, if you go to our blog, there's a post on about kratom, that addresses some of the concerns that you brought up, Dr. Berkowski. But I wanted to thank you and the 165 people that took time out of their Friday afternoon to join us for this webinar. But everyone have a great weekend, and thanks for joining us.